Welcome back to Psychiatry Boot Camp. Today we are going to try and demystify depressive disorders. The flagship diagnosis in this category that most clinicians will use most often is major depressive disorder. And we do spend most of our time addressing this specific diagnosis. We walk through assessment strategies, pearls for making management decisions. We discuss the underlying neurophysiology and conclude by introducing you to some first-line treatments. Our guest this week is a professor of psychiatry and pharmacology at the University of Toronto, Dr. Roger McIntyre. Dr. McIntyre was our guest for bipolar disorders last week, so we will skip over my joke about his litany of an email signature. Once again, number drop his greater than 700 peer-reviewed publications, and get right into content. Welcome, Dr. Roger McIntyre.
Pleased to be with you, and really enjoyed our last conversation, and so much to talk about as relates to depressive disorders.
Yeah, I would think that this will be one of the most listened to episodes. It's one of the most common diagnoses, one of the diagnoses that we talk about probably the most in the popular press and people's everyday life. So really excited to be covering this. So I'm going to start with kind of the central question, which is, in thinking about depressive disorders, I think it's very obvious that everyone will experience a low mood at some point in their life. And they should, to suffer is to be human. I think about the Four Noble Truths in Buddhism, for example, when I think about this, they always kind of come to mind. There's nothing necessarily disordered about human suffering. So my
Right.
question for you is, where do we draw the line between a low mood and being diagnosed with a mental disorder?
Well, that's a good point, and that's I think a point that would apply to all mental illnesses. Where is that point that this is in quotes normal versus in quotes abnormal? And there's different ways that one can define and operationalize normal versus abnormal. But the guiding principle that the DSM-5 text revision has taken, which has really been the guiding principle for quite some time, is does the does the disturbance, this disturbance we're talking about in mood, does it cause suffering? Is it suffering that is endured for a long period of time? And or is it resulting in obvious impairment in someone's life? So you're right. I mean, we suffer as humans. There's bumps and bruises to life. Some stressors are more severe than others. Many have gone through bereavement. That is a phenomenon very similar to depression, but different. We don't call that depression. We call it depression when the symptom of mood disturbance, along with some additional symptoms, is so prolonged and causing so much suffering. That's not normal. Or if it's causing, inability to fulfill one's role. That's the guiding principle in psychiatry. And I think, frankly, for me, that fits quite well with how I would sort of conceptualize normal versus abnormal.
I like it. I think that's very clear for us. So let's go ahead and jump into those symptoms that you're mentioning. So when we are talking to a patient who is reporting low mood, what are the additional symptoms that we're looking for when we are considering a diagnosis? And let's, this is on depressive disorders, but let's talk about the diagnosis of major depressive disorder.
Yeah, and this is not just a clinical point. Semantics and words matter. You know, these used to be called mood disorders. Now they're called depressive disorders. I'm not so sure that's still quite accurate in the sense I still see lots of people. I say, guess what, Miss Jane Doe, Mr. Doe, you've got depression. I say, I got depression. I'm not depressed. Why are you saying I have depression? And back in the old days, I say, you have a mood disorder. Really? I don't have a mood. My mood's fine. But so what they're reporting, though, is an absence of any joy, any pleasure, any sense of joie de vivre, any sense of looking forward, any sense of vitality. And then along with that, they maybe have disruption in their sleep, their appetite, their libido, maybe can't focus, can't concentrate, things like that. And so, frankly, part of this is not an easy task to come up with a moniker, a name, a category that really accurately captures what is depressive disorders. For now, we've landed on depressive disorders because depressed mood is one of the features, but it's not required to have the diagnosis of a depressive illness. You could have anhedonia as long as you have other symptoms that meet the requisite threshold in this so-called polythetic list that you can pick from in the DSM. So for me, what's most common in my experience, not so much low mood, certainly very common. 60 to 80% of people have low. But what's more common, more consistent, more enduring, more problematic, more debilitating, much more focused clinical concern is people just lose pleasure, they lose interest, they don't feel much joy in their life. And it's these facets that are part of the definition, but also I think are much more resonating with people with lived experience. And I think in different language, that's how they communicate the paradigmatic disturbance of depressive disorders through this experience of the absence of joy and pleasure.
So you're describing there the two core symptoms of major depressive disorder, anhedonia, and then the low mood criterion. Am I understanding correctly that in order to have this diagnosis, you do, though, in fact, need at least one of those core features?
Correct, correct. One or the other. But you don't need to have depression to have a depressive disorder, but you need to have anhedonia. Absolutely.
So one of the critiques that I hear a lot about this diagnosis is people saying, well, there are so many things that can cause depression, but we lump them all into one label of MDD. And you mentioned, for example, bereavement earlier, which is different but similar.
Yeah.
And if I understand correctly, it used to be that we did actually kind of subclassify depressive illnesses into different subtypes. Could you provide any context for me here to help me understand how we got to our current construct of major depressive disorder?
Yeah, I think there's an acknowledgement by the DSM right at the get-go that really the category depressive disorders is not to tacitly imply this is a monolithic organism, this is a single dimension entity. There's a recognition this is a group of disorders. It's a bit like saying infectious diseases. It's a group of disorders that are under the category infectious diseases, but they're all very different. And with respect to depressive disorders, people have done this interesting exercise. They've gone to the DSM. They've looked at the 9 items in the definitional criteria, the polyphyletic list, and they've just done a simple calculation. How many combinations of symptoms can you get? And they've added up over 1,000 combinations just therein. And so that really speaks to the phenomenologic heterogeneity. But to your point in the question, there's tremendous causal and pathoetiologic heterogeneity. And so I see depression as a group of disorders, and it's a group of disorders that represent in many ways a final common pathway. And I think that today we still are landing on the conclusion that we don't have this fully sussed out, the pathogenesis of depression. We've got lots of leads. We know there's a heritability component, but there's also an exposure component and exposures that affect brain development, brain health, and so on. And so there are many different ways one can end up depressed. One of the aspects about depression for me as a clinician for 25, closer to 30 years, but we'll say 20, keep it lower, 25 years for now, is that there's this notion that you have to have a reason to be depressed. A romantic relationship that broke up, the loss of a job, maybe it's bereavement that's been protracted, maybe it's some traumatic event. And there's no question that people report these types of stressors, if not recently, in the not too distant past, that preceded the onset of depression. But you don't need to have, in quotes, an event to trigger depression. And again, this speaks to the heterogeneity, the causal heterogeneity. It speaks to what's occurring underneath the surface, so to speak. But I think today in 2023, 2024, 2025, the conceptual framework is these are a group of disorders that represent a complex multifactorial interplay between genetics, epigenetics, and the environment.
When we think about treating major depressive disorder, are there any maybe subtypes, or I guess in today's language, it would be like specifiers that you would use, different sort of features that we look for with depression that can help us when considering our formulation, our treatment approaches?
Yeah, you're right. So the DSM has stayed away from subtypes. They don't use that language, as you know. They've gone with specifiers. And I suppose that's probably a more descriptive rather than categorical way to do it. Within the DSM, if one again takes out their calculator, there's almost 9 different specifiers that apply to a depressive episode. And the reason why the DSM wants us to do this is because it has relevance. And people might say, well, relevant in what way? Relevant academically, relevant clinically, relevant to how I pick treatments. And I think there's still a debate going on as to whether some of these specifiers are actionably relevant in the sense it's going to categorically change what you're going to do. But I do think there's a strong argument to make that there are reasons why we should do this. Give me an example. Patient has major depressive episode. The diagnosis is major depressive disorder, and the person has psychotic features. They can be mood congruent or mood incongruent. Well, first of all, that's a very severe presentation. Second is the treatment options for that person would be very different than the person who has depression in the absence of psychotic features. Another example would be a depression with peripartum or postpartum onset. Again, there's different considerations one has to think about, not so much pathoetiologically, of course, but more sort of concretely, clinically. And now we've got new treatment options for postpartum depression, and that needs to be considered. One final example is others. For me, I've had a lot of interest in mixed features. And the mixed features specifier applies to a depressive episode. And it doesn't necessarily mean you have bipolar, although you could, because hypomanic symptoms can affect people with major depressive disorder. It's just that if you have them, there's a greater likelihood you will eventually declare yourself as having bipolarity. Why I think that's really important is because when we give people antidepressants, SSRIs as an example, who have a depressive episode in bipolarity or MBD, who have mixed features, they have a very high probability of untoward outcomes and a very low probability of good outcomes. And there's been a real clarion call now to change how we treat this altogether. So I think that there are reasons why these specifiers matter. They do denote a different biophenotype to some extent with different response characteristics. And for the busy clinician, they don't have time to go through all of this. I mean, why should I care? Well, it does matter because it does affect your care plan and the individual choices within the care plan in many of these cases, but not all of these cases. And I'll maybe finish on that note by saying melancholic depression versus atypical specifier. Is that going to radically change what I'm going to do in clinical practice? No, it won't radically change. There's some overlap, some differences, but for the most part, some of these specifiers are relevant, I think, more academically still, but not for day-to-day clinical practice.
Yeah, thank you for running us through all of those. I think the melancholic features and the atypical features, I think there's some misunderstanding around that. Could you just lay out for us, what do you mean when you say melancholic features and what do you mean when you say atypical features?
Yeah, this has such a rich history. And by the way, nothing's more interesting than the history of psychiatry and the history of how these phenomenologic entities became categorized in the diagnosis and so on. Melancholic depression, I mean, that goes way back to antiquity. But more contemporary psychiatry, melancholic depression was really referred to the depression that was innate. It was intrinsic. It wasn't a reactive depression. It was a real endogenous depression. It was a real depression. And it was a depression where the patient was profoundly depressed, worse in the morning. They were profoundly impaired with fatigue. These individuals would often have paralyzing guilt and self reproach. And these were persons who often were on inpatient units. And at the time, psychiatry thought this is a unique subphenotype and would preferentially respond to male inhibitors and ECT. In contradistinction, atypical depression had more a reactive element to it. These people had exquisite mood reactivity. And along with that, they had atypical reverse vegetative features. They would eat more, they would sleep more, and be very tired throughout this journey. And people thought that was a different phenotype altogether. It had different response characteristics, etc. Where we've landed now is that, yes, there are these types of phenomenologic characteristics. It turns out that SSRIs and other antidepressants can treat melancholic depression. It treats out there's nothing unique about atypical depression in the sense that it can respond to a whole different assortment of medications. And it turns out that some really high quality symptom structure studies have shown that the great majority of people with depression have a bit of both symptoms, actually. So it's not really a discrete subphenotype. Nonetheless, I still ask about this because there's some work, for example, from Holland. We know that people who have depression are more susceptible to obesity. Well, details matter. It turns out that people with depression more susceptible to obesity are people who have atypical depression more than melancholic depression. And that's not just academic. Because when I'm seeing a patient, I don't just want to treat the depression. I want to forecast, prognosticate, prevent comorbidity like obesity. And if you have a typical depression, that's more of a light bulb moment for me because that's the person I got to really make sure I ramp up my emphasis on diet, exercise, lifestyle. That's not to say I'm not doing it in other patients, but obviously you triage and you allocate your time tailored to the personal characteristics of the patient. So it is relevant, but I think it has a really more interesting historical notion that has been really not supported by more recent research.
Gosh, that's brilliant. Thank you for sharing all of that with us. I think our listeners will find that really helpful. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I use to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word bootcamp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. Okay, so moving into some epidemiological information, when do depressive disorders typically present?
Depressive disorders have not only heterogeneity in terms of phenotype and causal factors, but also age of onset. That being said, when one looks at the age at onset of MDD, at the very least, we see a bimodal age at onset, if not a trimodal, but certainly a bimodal in late teens, early 20s, in mid to late 40s. And what we do know is that depression that begins early in life, especially in adolescence, clinicians are encouraged to really look for the possibility that this is bipolar disorder. In other words, when depressive episodes begin in any time in life, what we often say is that about 1 in 5 depressive episodes is bipolar, the remaining is major depressive disorder. So that's 20%. In adolescent or late adolescent onset, it could be closer to 30% in some studies, maybe even higher. So we have a bit of a bimodal onset in depression. One final comment is depression can begin for the very first time in older age. And older age is I guess it's a sensitive topic to define, but we'll call it over the age of 65. And depressive symptoms and episodes can clearly begin for the first time then. But I think when we're talking about depression, then we're also asking clinicians to be vigilant for medical comorbidity as being least comorbid, more commonly seen in people who have cerebral vascular disease, things like that. But also, is it a predecessor? Is it a prodrome to a cognitive disorder like Alzheimer's disease or something of that nature? So bimodal is the short answer. It tends to be more early age in most people.
Yeah, so to the older adults question, to our third-year medical students, this will be on your shelf exam, so-called pseudodementia, an older patient
Yes,
who has
yes,
memory problems, and it turns out, they give you all the depressive symptoms, and that is the answer on the shelf exam. But
yes.
Dr. McIntyre is taking us beyond that and saying, really, in clinical practice, when you see an older adult with first-time onset depression, you want to really put your medical hat on and start ruling things out, thinking about,
Yes.
is this early major neurocognitive disorder, et cetera.
Right. Absolutely.
So if people experience one major depressive episode, does this mean that they will for sure experience another where they will struggle with this condition for the rest of their life? What do we know about this?
Categorical answer is no. One depressive episode does not guarantee a lifetime of recurrent episodes or chronicity. So that is truly the case. Unfortunately, it's also the other truth that the majority of people will have at least one other relapse. And many would know that relapses beget relapses. So the more relapses you have, the more prone you are to it. And so everyone wants to know when they have a depressive episode, what's my long-term outcome going to be like? Is this going to come back? Do I need to take treatment forever? These are questions we are asked every single day. Now, we are not completely in the dark. I would say we still don't have the forecast ability that we would like, but we do have some ability to reasonably prognosticate the probability of recurrence. A person who's had a depressive episode, who is someone who's had a depressive episode that is typically in the context of identifiable interpersonal triggers, a person who has many supports in place, who has a resiliency with respect to their ability to be adaptive to circumstance. There are a number of different security aspects in place: financial, housing, job, relationships. A person who's responded fairly robustly to acute treatment, whether it be CBT or to a medication or whatever, with minimal residual symptoms, that person's got a pretty good prognosis. That person probably doesn't have to be on, if it's medication, if they go that way, for much longer than, say, 6 to 9, 6 to 12 months after the index episode resolves. And many of these folks will live a life completely without depression. Others, it's sort of obvious in many ways, people who've had chronic depression or people with multi comorbidities who have insecurity of home finance, healthcare, relationships, and so on. People who've had residual symptoms are people more prone to relapse. I think the other part too is that when we look at certain symptoms of depression, certain symptoms as part of depression have a little less favorable prognosis. For example, if you've had psychotic depression, even if you respond crisp and clean and robustly, which is great, you have a bit more susceptibility to relapse just by having this. That's a very severe presentation. Another example would be somebody who has profound anhedonia. For reasons not known, anhedonia doesn't cooperate as much with SSRI treatment. It tends to linger, can often be a predisposing factor to relapses. So that's also another one we keep a close eye on. And just to step into another area, just finally, women who have depression in the third trimester or peripartum, postpartum, we're always asked as clinicians, am I gonna get depressed again, either related to a subsequent pregnancy or not? In other words, what have you. The answer is yes, that you're at higher risk of subsequent pregnancy-associated depression. That's true. But with respect to non-pregnancy associated depression, there's a risk, but the risk prognosticator, or the risk calculator, so to speak, is similar to what I articulated earlier, if you will. Do you have strong supports? Are you a person who the depression was brief, well characterized, responded well to treatment, no comorbidity, no residual symptoms, absence of security, and you're not lonely? Then the outcome is pretty good for the most part. But even in that situation, and I've seen this firsthand in 25, 30 years being doing this, and that even in people who've lived the most remarkable, successful, supportive lives and are incredibly adaptive people, if they have pregnancy a second or third time, it's more vulnerable for them for relapse. Absolutely.
Mm. So you're reminding us of a couple of things. That's a tremendous amount of information. One thing is we don't check our common sense at the door. A lot of these kind of risk factors that you mentioned,
Sure,
they just
sure.
make sense to us
Of course.
clinically. And thank you for laying out all those specific things to consider. On the other hand, mental illness does not discriminate, because you have a
Yeah,
successful job, you're doing well,
right.
you have a family life that other people would look at and say, wow, aren't they so lucky? Yes, you can still get depressed. I think we've all seen many of these patients, and it's always sort of surprising to me how much mental illness does not discriminate. So thank you for that reminder.
Yeah, absolutely.
How common is major depressive disorder?
It's certainly very common, and people describe the prevalence of the condition as either point prevalence, 1 year, or lifetime. The point prevalence, in other words, how common is depression today in society? If you just walk down Main Street and talk to 100 people, Most estimates come in around 5%-ish. Again, there's plus or minus to this, but 5% is the where most studies land on. Lifetime prevalences, epidemiologists kind of cringe a little bit with lifetime prevalence because memories are not perfect and you're trying to remember, did you have a depression 20 years ago, 30 years ago, all that. But we tend to talk about it in one, current point prevalence, 1 year in lifetime. And obviously memories are a little better today than they were 30 years ago. Nonetheless, lifetime prevalence estimates, depends on the study, comes in somewhere between, here's the range, 12 to 18%. So there's a bit of a range there. There's no question that there are regions of the world where the estimates are higher, regions where it's a little lower. Here in North America, in the United States and Canada, we tend to be on the higher end of those estimates, if you will. Some might say, well, it's because of reporting differences. That could be true. Is it a true difference? Don't really knows. But these are common conditions. Obviously, events, macroeconomic events, social events, major political events can affect prevalences. For example, we know that during the pandemic, there was a striking increase in the rate of depression. This has been well documented around the world. And of course, you look at other situations like economic stressors. I wish the pandemic also was an economic stressor. But you look at, for example, the Great Recession that's accompanied by unemployment, or employment insecurity, the Hong Kong financial crisis, Asian financial crisis. We did see an increase in rates of depression, and so on and so on. So I think that, the rates have been remarkably high, and we used to think that depression was a mild illness. It's been reclassified as a more severe illness when you look at the effect it has on human capital, human function, disability. So it's not just a common, it is a severe disorder. I remember when I started my career, we called it a common non-severe disorder. Now we call it a common and severe disorder.
This has gotten a lot of press recently, and really we should spend hours and hours and hours on this because there's been so much research published on it over the years. And there are amazing podcasts and ongoing debates and journal articles about this, but Psychiatry Boot Camp is not one of them. We are not going to get into all of these debates. We just want to keep things clinically high yield and talk about kind
Yeah.
of what is settled out and the generalities in this boot camp setting. So, what do you think every new psychiatry trainee should know about the neurobiology of major depressive disorder?
I think the words plasticity should be the tip of the tongue of every clinician and every person in training. Plasticity, I would even go as far as to say network connectivity, and then the rest is gravy. I mean, and what I mean by that is that the science is abundantly clear, and we adopted empirical method in science. The science has been consistent that in the brain of people with lived experience of depression, there is something categorically wrong with the way that the brain circuits and networks are functionally and structurally connected. So I always use the metaphor of the motherboard on the PC at home. There's something wrong with the motherboard. It's just categorically, and it's reproducibly, it's a high effect size finding. And now those are circuits and networks, and those are comprised of neurons and glia. And so the cellular connections are plasticity. And in postmortem brain of people with lived experience, or you do animal stress research, it's highly replicated. There's something gone awry with neurogenesis, neuroplasticity, but also plasticity with respect to the dendrites, the dendritic spines. There's something clearly morphologically and functionally aberrant about the constituents of the circuits and networks being the cells. Now, we call these units of analysis, and I would just stop there. That is the prevailing view that there's something wrong with brain circuit network connectivity and depression, and that is comprised of cellular alterations in plasticity and trophic activity. Now, one can then can zoom in, use the kind of the Google Maps metaphor into even more units of analysis. Well, how did this happen? Well, you could in fact say that there was something aberrant about the neurochemistry of the brain. Now, of course, we've been worshiping at the altar of serotonin for 8 decades, 7, 8 decades, serotonin, norepinephrine, dopamine. But we haven't thrown that baby out with the bathwater, but we have other chemicals as well. There's GABA, there's glutamate. There's a lot of interest now looking at inflammatory markers. Maybe it's metabolic systems, orexin systems. There's now drugs in development targeting the opioid system. And then we can zoom in even further, get inside the cell, look inside the cell, look at the signal transduction cascades, look at organelles. Many people think that mitochondrial dysregulation is to explain what's going on in depression. 2 years ago, the FDA approved a drug called Auvelity, dextromethorphan bupropion. That's a drug that targets the sigma-1 receptor, which is located in the endoplasmic reticulum.
Wow.
So the organelles could be at play. And then many people have said, it's the signal transduction cascades that have gone awry. Lithium, one of the best drugs we have for bipolar disorder, affects the signal transduction cascade constituents. So one can, like a Google map, zoom further in with more granularity. But I think today we've landed on an empirically supported, highly supported, prevailing view. This is a problem with brain circuit in network connectivity, in function as a consequence of cellular, neurotransmitter, and subcellular aberrations.
So in some ways, it's the final common pathway then would be decreased neuroplasticity, decreased network connectivity. And then looking upstream of that, we can sort of say, why is that?
Yeah, 100%. Absolutely. That's why it is. And what's interesting is that when you look at treatments that we have for depression and you're agnostic on the modality, let's say it's an antidepressant or ECT or TMS or cognitive behavioral therapy, mindfulness, even some of the newer innovative therapies that are being developed, like ketamine, esketamine, maybe the psychedelics, like the serotonergic psychedelics, exercise, all of these modalities converge with respect to their possible mechanisms of action. What do? They reset the circuit. They reset networks and circuits and networks. They have favorable effects on neuronal and glial morphology, density, functionality, et cetera, et cetera. I think where how should I put it? I think where we kind of got seduced, maybe that's not the right word, but we had this notion that because we have serotonin drugs like fluoxetine, Prozac, then this must be a serotonergic depletion disorder. And I think it made for a very simple explanation. You don't have enough serotonin in your brain, give you a boost of serotonin, you're happier again. Makes for a great bumper sticker, makes for a great slogan. I don't think really people really were saying that. What they were saying was that's just simply the soundbite. What we were saying is that depression is multifaceted. There's many receptors, many neurotransmitters that are implicated. Um, Rather than having a deficiency, it's probably better to say there's a dysregulation in the system. And just because you have a drug that targets a receptor, that doesn't tacitly imply that the reversal or the effect must mean, if it's improving your mood, that it's corrected the lesion. So again, it's probably an overused metaphor, but if Tylenol helps your headache, you didn't have a Tylenol deficiency syndrome. And we seem to have had this kind of silly logic that because fluoxetine treats depression, you must have a serotonergic deficit. And this has led to some people, which is really unfortunate. Psychiatry, unfortunately, has never had a shortage of critics and armchair experts who said, well, something, the serotonergic hypothesis of depression has been overstated. Therefore, the drugs must be overstated. It's a bit like saying that the Tylenol deficiency hypothesis of headache has been overstated. Therefore, Tylenol doesn't work. It's the same similar silly logic that just gets in the way of helpful dialogue for patients. And unfortunately, psychiatry's been a little vulnerable to that.
Mhm. Yeah, I think with that whole controversy that has unfolded, when I initially was reading some of the stuff about, well, the monoamine hypothesis is incorrect. I thought, who understood the monoamine hypothesis to simply mean one single deficiency in serotonin
No,
explains every case of depression ever? I don't think people operating at the academic level typically think that, but I guess we have to acknowledge that that's the way it has been understood. And
sure.
like you said, some people do have a vested interest in oversimplifying these things so that people
Yes.
consume more of other things.
Sure. Sure.
One other area that I want to talk about is BDNF, brain-derived neurotrophic factors. So
Yeah.
in some of my reading on this, it looked like one
Yeah.
replicable finding was that BDNF is relatively low in patients with MDD.
Yeah.
And I know this showed up on an exam recently as well. Is it an overstatement to say that all effective therapies for MDD increase BDNF activity in the central nervous system?
I've not for political reasons or just to be diplomatic or anything like that. I'm always cautious about never and always. Those are two words I've tried to extinguish my vocabulary.
Totally.
Um, that being said, I'm not aware of, there could be, I'm prefacing with I'm not aware of, an example of an effective therapeutic, demonstrated effective therapeutic for depression that does not have some beneficial effect on, if not BDNF. There's about a dozen trophic factors. BDNF is sort of the best known one, most studied, very replicated, high effect sizes. I'm not aware. There could be one. I'm not aware of one. So yes, and this is also further instantiating the hypothesis with because we say that there's something wrong with trophic support in the brain that's leading to depression, and just so happens that we're missing many of these trophic supportive proteins. And when you give an effective antidepressant, you get a boosting of the trophic proteins in the brain. So it's a nice story, and and rather than the Prozac boosts your serotonin, therefore you have a serotonin deficiency syndrome. This is different because this is mechanistically informed. We look deep into the brain, and aha, we have discovered you have a relative decrease of BDNF and other trophic proteins. Aha, these treatments, it doesn't matter what modality they are, even exercise can boost your BDNF. Aha, when we do so, you start to see more neurons, greater neurite expression, dendrites are growing and connecting, more synaptic plasticity, better circuits, better networks. So it comes together mechanistically in the sense that we're getting the horse in front of the cart rather than just trying to serendipitously discover a drug and then try to figure out the disease somehow through the mechanism of the drug, which is the way psychiatry's been doing things forever. So it's mechanistically informed, and that's what gives it much more compelling validity.
And it's sort of at that final common pathway level of thinking.
Yes. Yes, absolutely.
Okay. Any other comments on the neurobiology of depression, or shall we move into management?
Well, I think just one other comment. I think that I think that there's many different mechanisms, and I think that yes, there's no question these are proteins, but what we're really seeing is convergence. Convergence with respect. We talked about circuits and networks, but many of these drugs that we give for depression, like Prozac, well, they affect BDNF, they affect inflammatory systems, they affect metabolic systems. So a lot of the language and a lot of our explanatory models is a consequence of where the street light is shining. And now there's been more interest in inflammation, metabolics, cellular energetics. Um, we're finding out more about what these drugs do. So, yeah, I think the drugs we have are also pleiotropic. They're not just so narrowly working. That's where the street light was shining.
Perfect. So, broadly speaking, in terms of management, of course, we have psychotherapy, we have medications. We've studied this again and again. We know that psychotherapy works. We know that medications work. We know that they work best in combination in broad strokes. Let's kind of separate them out here, starting with psychotherapy. Are there any specific psychotherapies that you would say have the most evidence for treatment in depression?
Well, the psychotherapies that do have the most evidence have been well described. These would be manualized psychotherapies like cognitive behavioral therapy, interpersonal therapy. There's data from so-called newer generation psychotherapies like mindfulness therapy and also behavioral activation therapies. They are proven effective in mitigating depressive symptoms. They can be delivered in individual paradigms or in group paradigms, group formats. And now, of course, the pandemic accelerated the acceptability of virtualized guided psychotherapies. We have a terrible supply and demand mismatch. The demand for these services is enormous, and the supply is not nearly what what we need. So to have computer assisted psychotherapy felt very bizarre 20 years ago. That's no longer considered bizarre. Guided CBT, for example, through the internet has been shown to be highly effective, highly acceptable to the end user, cost effective, less stigmatizing as well. Of course, there's a huge scale and access need that it can address. So the CBT, IPT, behavioral activation, and mindfulness have certainly been well established as effective in depression.
And you're just giving us a nugget there of the problem that anybody practicing in mental health in the United States today knows, which is it's very difficult to get into psychotherapy, especially find a
Yes.
therapist that you like, high quality psychotherapy, evidence-based psychotherapy. So I kind of appreciate your point there and a nod toward the future. And then moving into medications, I know this is the area where you've spent a lot of your career researching
Yeah.
this, writing about this. So, if you could kind of walk us through, let's just think about a patient with a first major depressive episode. What classes of medications are we thinking about here?
Yeah, absolutely. And certainly medications would be a first line consideration, a first level therapy. Uh, Parenthetically, I'm fully aware of the fact that formularies and algorithms that different care plans have often influence this. But that aside for a moment, let's just talk about what's available. And certainly across the United States, SSRIs are often prescribed first, which is not unreasonable. But I would say that it should not only be your first line in a treatment naive patient. I would consider SNRIs, multimodals like 40-oxetine. We now have some 5-HT1A agonists like gepirone. We also have bupropion. And we also have the first NMDA sigma 1 agonist being dextromethorphan bupropion. And I think that when it comes to depression, I think we need to be aware there is more than just the SSRIs. There has been some different options, and they are different in their profile of efficacy, tolerability, and acceptability. So I think people should be aware of these different classes.
How do we go about selecting the right med for the right patient? If we have all of these options and we only have
Yeah.
one diagnosis, major depressive disorder, do you just throw a dart at the wall or roll dice or
Well, I think there's always going to be a certain level of clinician's choice or patient's choice on this, if you will. That being said, look, there are scenarios where you'd be guided towards one treatment or the other, for example, based on phenomenology. If the person had profound anxiety, I wouldn't start with a bupropion. It may be too anxiogenic. I might go towards an alternative. If the patient, along with depression, has terrible neuropathic or musculoskeletal pain, you might be gravitating more to an SNRI. If the person walks in and says, guess what? I've got depression. I want to stop my cigarette smoking. I think I got a bit of ADHD. That might guide you towards a bupropion. Patient says, I got a lot of cognitive problems. I can't focus. I got brain fog. I'm so depressed and brain fog. You're thinking more of a vortioxetine or an SNRI. Or the patient says, guess what? I've got depression, but I've also got OCD. I've got PTSD. I've got panic disorder. You're thinking more SSRI. So there are some of these ways that we stratify. Clearly, nobody wants side effects. Weight gain, metabolic disruption, sexual dysfunction, these are obviously non-starters. And when you start taking the medications, actually, and filtering them on the basis of which ones don't cause that and which ones do, the ones that don't cause that is not a long, long list. So we have drugs like Remeron that don't cause sexual dysfunction, mirtazapine, but it is sedating and causes weight gain. Gepirone's a new entry. It doesn't cause sexual dysfunction or weight, neither does vortioxetine. Some of the SSRIs are less likely, they still cause it, like sertraline. And again, I think, vortioxetine doesn't cause these types of problems as well. So I think it really, one needs to know some of these granular details. I still cringe a little bit when I hear people say that they're all the same, pick one, anyone. That's not really true. They're quite different and they have different profiles that do matter to people with lived experience.
yeah. And of course, I am 100% kidding with my analogy of rolling the dice. It's absurd to me to think that you could be prescribing medications that affect someone's neurobiology, which I, consider to be kind of part and parcel of who they are as a person, and not have a really strong command of the different ways that these various classes of medications affect the brain. Because as you laid out, we're now at the point where we have many different classes of first line options for major depressive disorder. Within each class, you often have several options that you can choose. And so, if you're going to have the sacred responsibility of helping to recommend a medication to a patient that is going to change their neurochemistry, it's really important to have a strong command of all of the options in our arsenal, all of the tools at our disposal.
I completely agree. And, I've met so many patients over the years where they fail an SSRI, then they go to another SSRI, then they try a third SSRI, and then they get referred for treatment resistant depression. I just changed the category of medications and they're better in 2 to 3 weeks. They didn't have to resistant depression. That's very common. So, and I think again, I think just over the years, I've been left with the impression, I think it's true, that many people are just not as familiar with some of these nuances that are different and meaningful between these agents. And no, they're not all the same. So I do think people need to be. I remember when I used to be a med student, I remember when I was, and I guess our colleagues who work in dermatology are going to cringe when I say this, but I think it's candid. I was told just remember one or two steroids and you're fine. And I doubt that's true anymore. But anyhow, you just can't know one or two antidepressants. You got to know the differences.
Yeah, you're definitely failing your patients if that's your understanding of
Yeah.
antidepressants. So here are my final thoughts, and then I'll ask you for yours. So one is I'm going to direct our listeners to a publication that you were a part of, Canadian Journal of Psychiatry 2016. This is from the Canadian Network for Mood and Anxiety Treatments, the CANMAT guidelines, clinical guidelines for management of adults with major depressive disorder. I will direct them there. And then my other final thought is the last time the American Psychiatric Association put out guidelines on this, I just sent this to my residents. It's like a 100-page document, and I started to read it. And what really floored me is the first recommendation in this 100-page document is, you guessed it, establish and maintain a therapeutic alliance. That
Sure.
trumps all of this. If you don't have a good therapeutic alliance with
Sure.
your patient,
Sure.
if you don't
Sure.
understand the patient, if they don't feel seen, heard, understood, then we're not even getting past the first recommendation
You got it.
from the American Psychiatric Association. So I think we need to keep that front and center when we think about treatment of depression. Final
Yeah.
thoughts from you, Dr. McIntyre, as we wrap up for our listeners.
Yeah, I completely agree with what you just said. I may also direct people to another recent publication, October 2023, World Psychiatry Association. I just led a group of people around the world looking at treatment-resistant depression. And I talk about how we can prevent treatment-resistant depression, not just treating it. And have a look. It's a free article download, McIntyre RS, World Psychiatry, Treatment-Resistant Depression. And I think what I tried to do is make the case that psychiatry has a phobia. It has a phobia of this vulgar word called prevention. And there's so much that we can do in psychiatry that's preventative, but psychiatry seems to have this very bizarre phobia of them. I'm being obviously a little facetious, but being serious at the same time. And so much can be done. And I was at a meeting. I'll finish this last thought. About 6, 7 years ago, it was this organization meeting in the hospital, which I don't usually participate in. But I was at this meeting and they were saying, "Oh, we want to develop a new center for depression." I said, "Okay, so that sounds good. We got some funding from a rich donor." I said, "Oh, great, great, great." And we're trying to figure out how it should be configured. I said, "Great." And we're thinking what we should do is put all the money towards treatment-resistant depression. I said, "Okay, I get the point, but I would suggest something different. Why don't you put all the money towards people who had a first episode of depression? Let's prevent treatment-resistant depression." And so I just want to leave with that because so much is the implementation gap, knowing and doing, and the doing and knowing are not the same thing. And if we just close the gaps, outcomes in depression don't need to be as miserable as they have been. And I just want to just leave on that note because the outcome doesn't have to be as bleak as it so often is if we would just close the gap. As they say in England, mind the gap. So we got to mind the gap. That's what I would do.
I like it. So we'll see if we can prevent suffering by kind of looking upstream and avoiding the
Yes.
need to funnel all this money into people who have suffered unnecessarily.
Yeah.
Okay. Well, thanks for coming back on the podcast.
Thanks for having me. It's been an absolute pleasure.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.